Good evening, everyone. Welcome to the continuation of the topics on respiratory system. So today's talk, I'll be dealing with ultrasound lung in critical care medicine. Okay. So this is something that we use day in and day out in the bedside, and as a routine, examination tool in critical care. So it is so extensively used that of lately the use of stethoscope has gone out of vogue. Okay, it might become a piece of instrument which will be in the museums in the long run if we continue to understand the art of ultrasound. So the role of USG in ICU is basically divided into two things. That is diagnostic on one side. On the other hand, it can also be used for any intervention or even for a therapeutic, procedures. Okay. So by and large, this is how we can broadly classify the role of ultrasound in ICU. So it can be used in various, measures in the ICU, be it in head and neck, like the ONSD, uh, transcranial Doppler, for the use of tracheostomy. Okay, lung ultrasound, that is the topic of the class today. 2D echo, again, a lot of abdominal scanning, be it your EFAST, etc., in emergencies, or fluid dynamics, assessment of volume status, and a lot of other things that you can think about. So much so that even it is being used for assessment of nutrition also in these days. Okay, so the use of ultrasound is increasing day by day, and the more we understand it better, we'll be able to apply better and have better outcomes at the bedside. So the advantages of ultrasound is the portability of the machine. It can be moved around without problems, unlike need for transportation of a patient, especially to a CT or an MRI. You can repeat it quite frequently, and you can also assess the improvement or deterioration based on your interventions. There is no radiation risk involved. The learning curve is comparatively easy as compared to other scans like your CT or MRI. And the thing is, it is much more cost effective as compared to the other modalities of radio imaging like CT and the MRI. So a lot of probes are usually used for ultrasound. It starts with your phased array probe, the cardiac probe, curvilinear probe, or the abdominal probe, vascular probe, or your linear probe, so on and so forth. But commonly, what we use for the lung ultrasound is the curvilinear probe and the linear probe. Okay, linear probe is basically for all your superficial structures like the pleura, and the curvilinear probe is for the deeper structures, especially when you are looking at the assessment for aeration, or you're looking for the presence of pleural effusion, etc. Probably a curvilinear probe is a better tool that you can use. Okay. So when we're talking about ultrasound, we're talking about lung ultrasound per se. How do we have to understand? Ultrasound is nothing but a pulse of sound energy, usually more than 20 kilohertz. Okay, so 20,000 hertz or above any sound frequency. If it comes there, it is called as ultrasound. So when ultrasound waves are formed and they're pulsed across a tissue, usually the reflected sound which comes back to the probe, that is your piezoelectric crystals, they cause a image formation, and that will be changed based on the transducer in the machine, and that will give you a pictorial depiction of whatever is underneath the probe. Okay, and how do we get that? Usually we get it under these images or image quality. Either the structure can be echoic, hyperechoic, isoechoic, hypoechoic, or anechoic or black. Okay, so it is usually the sound wave that is sent into the tissue, and then the reflected waves that are picked back on the probe, that which moves the piezoelectric crystal, which causes the formation of the image. Okay, and that helps us understand. Most of the times, whenever we're looking at tissues, if at all they're denser tissues, they will be reflected, and that causes an artifact. So by and large, air does not cause any reflection of the sound wave. It just helps it transmit across. It will let it go across. So that is the reason usually air will appear as black. Okay, but if you have certain tissues like subcutaneous tissue or a pleura or a bone, it will be appearing hyperechoic. Okay, so that is something which appears white on the screen. So this is a basic understanding of ultrasound. I'm sure that all of you are already aware of because you'll be using it day in and day out. Okay. So normal air-filled lungs is a poor conductor of sound waves, so it just lets it across. So you just see it as a black screen on the monitor. It will just appear as black. So pleura appears bright on the monitor. It is hyperechoic. The acoustic impedance of the pleura with the air underneath, which reflects the ultrasound waves, helps the operator distinguish between a normal lung and the pleura. So, what I mean to say by this is the normal lung appears to be black, and whatever appears in the space of black, a newer structure or a darker shadow or a brighter shadow, whichever comes in there, will be the artifact. Usually the artifact refers to the pathology which is present in the lung. For example, if it is consolidation, it will appear brighter. Okay, that will be in the parenchyma of the lung. So around a black C, you will see a white boat, just for an example or understanding. Okay, so that is how it is. Usually we use this understanding to pick up the pathologies in the lung. Okay, usually the most important thing is, firstly you need to understand what is normal lung. Okay, if you differentiate normal lung, then you will be able to understand what is the pathology. Okay, the pathology is usually the artifact which comes on the ultrasound. So coming to a few questions to make it less monotonous. So what are the probes usually used for lung ultrasound? That is your pleura or the lung parenchyma. Bhagishri, can allow them to unmute and answer.
So they can unmute themselves and answer the
Oh,
question.
that's great. Okay, guys, one of you can pick up. This is all very simple. You do it daily, right? What are the probes that you use for lung ultrasound? For pleura, what do you use? And for lung parenchyma, I've already given you the answer. So for pleura, we use the linear probe, okay, the high frequency one, and the lung parenchyma, the low frequency one, is what you use. Okay, so the 5 hertz probe is usually what is used for lung parenchyma. What is the ideal position for lung ultrasound? Usually supine is the best one, but semi recumbent up to a 15 to 30 degree head end elevation is also better. Okay, most of the patients we know in the ICU are sick. Probably they might be on a ventilator, so it will be difficult to keep them fully upright to examine. But having said that, there have been a lot of studies done in both critically ill and non-critically ill, where they have looked at the assessment of lungs in all positions possible, and there have been cutoffs based on the position. Okay, so usually for critically ill patients, the ideal position would be a supine position or a semi-recumbent position up to 15 degrees. So, name a few scenarios where USG can be helpful in the diagnosis of any pathology in the lung ultrasound. Any
Pulmonary
respiratory?
edema.
Very good. Pulmonary edema. Anything else? Only pulmonary edema. You can go on telling a lot of differentials. Huh? You can diagnose what all problems with lung ultrasound. Can you diagnose pneumothorax?
Yes.
Yes. Can you diagnose consolidation? Can you find out atelectasis? So all of this is possible, right? So you have to remember a few scenarios. Okay, guys, this is very important because this is going to be in your viva station as well. Okay, this can be asked as a question in theory, this can be asked as a question in viva. Definitely viva, they will start with a few basic lung ultrasound views. Okay, so please be attentive and please go back and read it up. Okay, so in the next slide I'll just show you an image. So can you guys identify the image? So it is both the linear and the curvilinear image of a lung ultrasound. Okay, so this is one thing, they'll just let it be across and they'll ask you to identify. So is this normal or abnormal lung ultrasound?
Normal.
Normal lung ultrasound. Okay, why do you say it as normal?
You can see the sliding.
You can see the sliding, is it? I have not put a dynamic image. Okay, but yeah, see a few things you can see. There is no B lines which is seen. There is the presence of the pleural shadow which is there. Okay, the pleural line is hyperechoic and it is uniform throughout. Okay, so since it's a static image, you can tell those 2 points along with the presence of A profile. Okay, so that's all we can tell. If they give you a dynamic image, then you can tell lung slide. Okay, here we cannot comment on sliding because you're not seeing a dynamic image. But good effort. That is a good thing. Okay, lung slide is actually an indication of normal lung ultrasound. Okay, good. So these are the structures. So you have the subcutaneous fat, you have the muscle, you have the rib shadow, which was seen earlier, okay, and then you have the thick white hyperechoic line, that is your pleura, okay. Then you have horizontal, repeated white lines which are present below the pleura, okay. So between the two rib shadows. So this is the A line, okay. So I'll be going ahead in the next slides talking about the definition of A lines, etc. So by and large, this is the normal linear probe image of a lung ultrasound, okay. You initially have the subcutaneous fat just underneath the probe. After that, whatever image you see is of the intercostal muscles, pleura, and then underneath the pleura, you have the lung, okay. So these are the two probes I've already mentioned earlier. This is the linear and the curvilinear probes. Okay. So what you need to understand is linear probes have a higher frequency. So whenever you have a higher frequency, the number of sound waves emitted per second will be very high. So what do we mean by that? It emits the sound fast, it will receive the sound fast. So it has to only go into a very short depth window. Okay, so that's the reason it is used for superficial structures. It can't go beyond that, okay, because it has to go fast, come fast. So it will give you a better quality image only in the superficial structures. So they are used for superficial structures like your cannulation of the catheters or the assessment of pleura, etc. Okay. Similarly, what happens in a curvilinear probe is a low frequency probe, roughly around 5 hertz is what they use. Okay. Whenever we are using a curvilinear probe, we actually have to compromise on the quality of the image. Okay, the only advantage is the depth of the image acquisition will be higher. Okay, so depth of acquisition is better with the curvilinear probe, but at the cost of the clarity of the image. Okay, because here the sound waves are produced at a lower frequency. So when it's produced at a lower frequency, it can penetrate into the deeper tissue and pick up the image which is present in the deeper part of the body. Okay, so that's why it is used for cardiac ultrasound and deeper structures of the lung, probably the lung parenchyma, abdominal ultrasound. Okay, so this is about the linear and the curvilinear probe. Okay, so how do you position the probe and the ultrasound? Usually there are two ways that you can do it when you're doing the ultrasound of the lung. Okay, so either you can keep it in a longitudinal fashion wherein you'll have an image as present in the left hand side of the screen, and you can also see the intercostal argin area. Okay, so between the two rib spaces, intercostal space, whatever is present, if you want to scan that particular intercostal space alone, then you can use an oblique scan view. But if you are comparing multiple spaces, usually you use the longitudinal scan. Most of the lung ultrasound, when we are talking about including the protocolized approaches, which I'll be dealing further, all involve the use of a longitudinal scan. Oblique scan is very rarely used. Probably for the identification of certain pathologies, it will be helpful. But by and large, what we use is a longitudinal scan. Okay. And when I mean by longitudinal scan, even if it is curvilinear or a linear probe, it should usually be present in a cephalochordate fashion. Okay. So when I talk about cephalochordate fashion, the pointer should be towards the head end. Okay. So that is how you need to keep the probe positioning when you do the lung ultrasound. Okay. Next, from probe positioning, we go to how to pace the patient. Okay, so when the patient, I've already told you, should be somewhat supine is the best thing. If you can make the patient move a little, semi-recumbent either to the left lateral decubitus or right lateral decubitus, it is a good thing. Okay, but most of the times we know patients are on the ventilator. It will be really difficult to move them across, and if at all they are having some ICD, etc., or a drain which is inserted anywhere, it will make things much more difficult for us. So having said all of that, we need to know the surface landmarks when we are talking about lung ultrasound. Okay, usually the lung is divided into two hemithoraxes when you are talking about lung ultrasound. Okay, the left hemithorax and the right hemithorax. When we are talking about the left hemithorax or either of the hemithoraxes, there are three vertical lines that you need to remember. Okay, the first vertical line would be, sorry, the first vertical line would be the parasternal line. The second vertical line would be the anterior axillary line, and the third vertical line would be the posterior axillary line. Okay, so if you understand these three, it is usually cut across at the level of the nipple into four quadrants. Okay, so this will be anterior part of the lung, and this will be the lateral part of the lung. Similarly, there is also the posterior part of the lung, which I will be dealing with in the next slide. Okay, so if you have understood that there are three vertical lines which are drawn and one horizontal line which are cuts across the nipple, uh, how many quadrants are formed? Four quadrants, right? Here, one, two, three, four. Okay, that will be anterior and lateral. Similarly, in posterior, if you go, you have two more added on. Okay, so five and six. Okay, so usually it is at the end of the spine of the scapula. Okay, so wherever this meets the rib here, that is roughly considered to be the cutoff margin for the posterior division of the quadrants. Okay, so each hemithorax is divided into six quadrants. Okay, so totally how many quadrants are there? 12 quadrants. So whenever we are going to do a complete lung ultrasound, usually it will be for 12 quadrants. But for most of the patients in the ICU, especially the ventilated ones, four quadrant ultrasound is usually what is supposed to be done at most. Otherwise, it will be incomplete. Okay, so the best would be to do all the 12 quadrants, but at least you should do four quadrants on each side. That will be eight quadrants in total. Okay, so this is about the surface landmarks. Okay, so can anyone explain what is PLAPS? Okay, after this image, can you tell me what is PLAPS? Okay, so PLAPS stands for posterolateral alveolar or a pleural syndrome. Okay, it is defined by the intersection of a horizontal line at the level of the lower blue point and the vertical line at the posterior axillary line. Okay, so exactly the pointer is kept here. Okay, so this posterior axillary line will be here, and then you have an intersection here. Okay, so this is usually the point where it comes. Okay, so this is called as the PLAPS point. So why is it important? Because this is usually where we get most of the pathologies of the lung. Okay, and this helps us understand better of the issue which is causing either respiratory failure, or sometimes even you can think about hemodynamic compromise related issues also we can pick up at this point. So that's the reason this is one of the most commonly used points. Okay, sometimes if they ask you which is the only point that you want to analyze mostly for hemodynamic changes, probably if you say PLAPS point along with the cardiac ultrasound, it will be ideal. Okay, so you will be able to pick up more pathologies using these two view on ultrasound. Okay, so earlier I spoke about landmarks, right? When we talked about the parasternal line, anterior axillary line, posterior axillary line, and the horizontal line at the level of the nipple. Similarly, there is another method wherein you use two hands. Okay, so here you must notice this. Okay, the thumbs are not included. Okay, usually the four fingers of each hand are placed. The upper hand is just below the level of the clavicle, and the lower little finger, the hand which is present here, would roughly correspond to the subcostal margin. Okay, so what you need to remember, the upper hand margin will be just below the clavicle, the lower hand margin will be at the subcostal area. Okay, so this is roughly how you divide the anterior chest into upper quadrant and the lower quadrant. Okay, similarly, and the opposite side also you can divide them. So if you're feeling that the nipple areal complex is not accurate, or if it is, if the patient has undergone a mastectomy, so on, so there is problem with identification of landmarks, this is one rough method that we can divide the quadrants. Okay, so this is about the surface landmarks. So earlier I spoke about two views, that is your linear view and the curvilinear view. Okay, this is one thing they will ask, what is the sign called as? Okay, the bat wing sign in the linear view of the lung ultrasound. Okay, whenever you see this, you can tell that it is a normal ultrasound or abnormal based on the structures that you see. If they have shown you the linear image, always remember the line here would be flat as compared to the curvy linear where it will have a dip. Okay, so then whenever they are talking about bat wing sign, it is usually in the linear view. Okay, so what you usually they mean by bat wing here is two ribs will be present and the intercostal space in between. Okay, so this part is usually associated with the appearance of a bat with its wing open. Okay, so that's why it is called as a bat wing sign. Okay, so what you need to remember is below the ribs there will be an anechoic part. Okay, you will not be seeing anything. It's going to be totally pitch black, and just in the intercostal space you will see the pleura, and below the pleura you can see probably A lines, B lines, or any other pathology if it is present. Okay, similarly what you see here is because it's a curvilinear probe, I told you it is a low frequency probe, right? So the depth of acquisition will be higher. Here, the depth of acquisition will be lower. You will see only mostly the superficial structures. So here, when you're seeing, you see a lot of repeated things, right? You see this horizontal line which is coming again and again, and as it goes deeper, it becomes less brighter. So this is what I meant by the image quality being lost in a curvilinear probe. Okay, so these are A lines. Okay, so this is again a rib, this is again a rib, and this is the intercostal space, and then you have the structures which are present there. Okay, so these are the basic views in the lung ultrasound. So earlier someone spoke about lung sliding, correct? So this is the image which usually they might give you in your Viva and ask you to identify. So you see this movement of the pleura, which is a bright line here, right? So the movement of the bright line, whatever you see is the pleura. What is moving here, the parietal pleura or the visceral pleura? What is the other names which are associated with lung sliding? Guys, you need to answer. This is a very basic thing which you do regularly in the ICU, right? So can you please unmute and answer? What are which pleura is moving here? Parietal pleura or visceral pleura? Then I'll leave it to you guys to find out and answer. Okay. So these are the structures. Okay. So basically, it's a linear image is present here, and these are the structures: the skin, the muscle, that is the intercostal muscle, the pleural line, and then you have the lung artifact here. Okay, so this is by and large the uh, labeling of the ultrasound which is present on the left side. So I've already dealt with what is A lines. I've also spoke about normal aeration of the lung. Okay, and then I've also spoken about the Plapp's point. So when we're talking about Plapp's point, usually the structures which are visualized here are lung, diaphragm, and the liver on the right side, and spleen would come on the left side. Okay, along with diaphragm and the lung. So you'll see the costal margin as well. Okay, so this is something that is usually present in a normal lung. So coming to the basic nomenclature of ultrasound lung, what are A lines? A lines are normal aerated lung. Okay, usually it's present there. So they are horizontal in nature, which appear at frequently evenly spaced intervals. Okay, so that is what you see in the previous image, right? You see them at a frequently placed interval. Okay, and they are horizontal in nature. So these are A lines. They are seen in normal lungs. Okay, and they are caused due to a reverberation artifact of the ultrasound. Okay, so it usually indicates a dry interlobular septa. Okay, and what I mean by dry interlobular septa is the chances of pulmonary arterial occlusion pressure will be low, and the chances of the development of pulmonary edema will be very less. Okay, so that's something about A lines. Coming to B lines. B lines are vertical hyperechoic lines. Okay, they are caused due to infiltration of the pulmonary interstitium. Here, A lines we talk about the interlobular septa, but when you're talking about B lines, it is about the pulmonary interstitium. It usually, as I told you earlier, it is a vertical line. It extends from pleural surface, extending in a ray-like pattern till the end of the screen. Okay, so this is how they look like. Okay, It usually cuts across an A line at the point of intersection and usually indicates the presence of pulmonary edema, which usually accumulates in the pulmonary interstitium. Up to two lines, especially two B lines in the last interstitial space, especially lower down, okay, is acceptable. Any segment wherein you see more than two B lines, then it is indicative of a probable development of pulmonary edema. Okay. So this is how a B line would look. Okay, B line usually is defined as a comet tail artifact, which appears as a vertical bright line extending from the pleural margin down till the end of the screen, which cuts across multiple A lines. Okay, so the best way to view it is the curvilinear probe, but even your linear probe also would pick up. Okay, usually up to two B lines per intercostal space is okay, especially in the lower air spaces. But if you see more than two B lines which is present, then it is indicative of a presence of interstitial edema. Okay, so that is the pathological finding. Okay, so that is about A lines and B lines, which are the most important, things that you need to know in lung ultrasound. So, what are Z lines? Can anyone answer? Okay, since no one is answering this also, I think I'll give you the answer. Z lines are just incomplete B lines, okay? They do not cut across A line. Usually they're present just below the pleural margin, but they just vanish after that, okay? So there is very little clinical significance with such lines. They are also, remember, Z lines are vertical lines, but they do not cut across A lines. So since you have not answered Z lines, the homework question would be, what are E lines, okay? So if you answer questions very nicely in the exam, especially in your Viva, the examiner might ask you these questions. Okay, these are all smaller points which can fetch you more marks in your exam. So the homework question, please find out what are E lines. Okay, so can anyone answer what is a lung pulse and where is it seen? So we discussed about few points which is usually defined in lung ultrasound, like A lines and B lines, and I also spoke about Z lines, and I asked you what is E line. So what is a lung pulse? So someone told about lung sliding. Okay, so is lung sliding and lung pulse same or they are different? Okay. So lung pulse is the pleural movement appreciated in sync with the cardiac cycle due to transmission of cardiac pulsations. Okay. It can be best appreciated when the lung movements are obliterated, especially when you have an endobronchial intubation. The cessation of lung movements makes the non-aerated lung, which is the lung wherein there is no air entry, susceptible to receiving pulsations from the heart. Okay, so that time you can see pulsations on the lung ultrasound. So especially the pleura. Okay, so they are called as lung pulses. Okay, so it is not an abnormal thing. The only thing is here the lung sliding will still be intact. Okay, and usually if you find that both lung sliding and lung pulse are absent, then it is an indication that the pleura is discontinuous. Okay, so when a pleura is discontinuous, the most likely pathology, if there is no fluid, would be pneumothorax. Okay, so coming again, lung pulse is the pleural movement appreciated in sync with the cardiac cycle. Okay, usually it is best appreciated when the part of the lung which is present is not getting aerated well. Okay, it can be seen in endobronchial intubation or if there is a subpleural consolidation also. Okay, so if you have some subpleural consolidation also, what will happen? The aeration of the lung will be minimal, and because the aeration is minimal, whatever cardiac pulsations are present, they will be transmitted across the consolidation into the pleura, and that for each heartbeat you will see a movement in the pleura. Okay, so that is called as a lung pulse. So whenever there is a breach in the pleural lining, okay, this will be lost. So whenever you have loss of lung pulse or loss of lung sliding, you can think about the probability of a pneumothorax. Okay, so this is one reason why this becomes important to know. Okay, So coming to the various pathologies, so we have learned a few of the definitions and important image findings in lung ultrasound. So now we will go on to the pathologies. Okay, so we were talking a lot about pneumothorax. Okay, so we'll start with that. We'll go on to interstitial syndrome, consolidation, and pleural effusion. So whenever we have a lung ultrasound, you have lung sliding, which is usually present. So you will see, if you're seeing lung sliding, which is present, you have A patterns, okay, and then um nothing like pulmonary edema features, like no multiple B lines which are present, then it is a normal lung ultrasound, okay. But if the lung sliding is absent, okay, and then B lines are present, then also you can rule out a pneumothorax. But if you see lung sliding which is absent and only A lines are present, then you have to further evaluate for the probability of a pneumothorax. Okay. So remember, B lines, if they are present in the absence of any lung sliding, is still unlikely that the patient has a pneumothorax. Okay. So if at all B lines are present and you're thinking of pneumothorax, then you have to look for other causes. If other causes are not there, then only you have to think about pneumothorax at that particular time. By and large, majority of the times, whenever there is B line present, that means you say the lung at that particular place is still present and the pleura is not given way. Okay, and the pleura is not given way means there is no pneumothorax which is formed at that point. Okay, so remember, if there is absent lung sliding and presence of only A lines, then you have to further look for lung point. Okay, what is a lung point? It's a transition between the normal lung sliding point and the point of pneumothorax. Okay, so the transition point between the normal lung and the lung which has involved pneumothorax is called as the lung point, and this is 100% pathognomonic for the diagnosis of pneumothorax. Okay, so there are a lot of protocols which are usually present, especially for the diagnosis of acute respiratory failure. Okay, like Luke protocol, etc. So which uses some of these findings to categorize various pathologies in the lung. Okay, so I'll be dealing with that in the later slides. For now, you understand, whenever you're thinking of a pneumothorax, look at lung sliding first. Okay, if there is lung sliding present, if there are A lines with or without B lines, then it is a normal lung. But if there is no lung sliding, but there are B lines, again think of any other pathology apart from pneumothorax. But if there is no lung sliding, but there is A lines, then you have to think there is a possibility of a pneumothorax. And when you think there is a possibility of pneumothorax, the only way to find out is two things. Okay, you have to use lung point, which is almost 100% accurate, and there are other signs which you usually use. Okay, that is usually your M mode. Okay, so when you're using your M mode on ultrasound, that time you see something called as the stratosphere sign or the barcode sign, and if they are also present along with your lung point, then it becomes 100% accurate of a presence of a pneumothorax. Okay, so this is by and large how you go about the diagnosis of pneumothorax. Okay, so this is one image wherein you can see there is no lung movement, right? So there is no lung sliding. Okay, so whenever lung sliding is present, you see something like a marching of the ants in the visceral pleura, correct? So when the visceral pleura is not moving and you see just a bright white line there, the probability of a pneumothorax goes up at that point in time. Okay, so that time we might have to do the B from this is a B mode. Okay, the B mode is also known as the brightness mode. Okay, from the brightness mode, you have to switch over to the motion mode, that is the M mode, and then look for the presence of a stratosphere sign or a barcode sign. And when you're doing so, you should also look for the presence of a lung point. Okay, I told you earlier, I'm repeating again. Lung point is the transition point between the normal lung and the lung which has been affected with the pneumothorax. Okay. So this is the seashore sign. Okay, seashore sign is the sign which is usually present on the M mode of a normal lung. Okay, so you see initially there will be a chest wall sign wherein you see the uh, waves crashing onto the sand bed. Okay, so that is how they describe the seashore sand as. Okay, the upper half responds to the chest wall, and the lower half responds to the lung parenchyma. Okay, so this is the normal lung. Normal lung, you have the seashore sign. Next, you have the pneumothorax. So in pneumothorax, I told you earlier, what we see is uniform horizontal lines there. Okay, so this usually refers to the stratosphere of the sky. Okay, so that is why it is called as the stratosphere sign, wherein everything looks straight. Okay, or else this is something which we see on all the packaging, which we see, that is your barcode. So that's why it is also called as the barcode sign. Remember, the presence of stratosphere sign or a barcode sign is not pathognomonic for pneumothorax. Even though it is present, you might, for the confirmation, you should always do an assessment for the lung point. With these two, if you have lung point present, then it is 100% accurate. Okay, so the accuracy with these two things would be less. Even though they are associated with pneumothorax, if you find a lung point, only then we can confirm the presence of pneumothorax. So in 2012, the international consensus, conference came to an understanding that few things have to go in an order for the diagnosis of pneumothorax. They are as follows. Firstly, you should have absence of lung sliding. Okay. After absence of lung sliding, you should also have absence of B lines. You should also have an absence of lung pulse, as I told you earlier. Okay. So when you have all of this absent, that is lung sliding, B lines, and lung pulse, and you have a presence of a lung point or multiple lung points, then the probability of this patient having a pneumothorax will be higher. Okay, so these are the guidelines, or these are the prerequisites for the diagnosis of pneumothorax. Okay, if someone asks you what are the sonographic signs for the definition or the diagnosis of pneumothorax, you have to mention all of this. That is absence of lung sliding, absence of B lines, absence of lung pulse, and presence of lung point. Okay. So I was telling you earlier, okay. So lung sliding, no lung sliding. Lung sliding sometimes can be erroneous also. Absent lung sliding can be also seen in subpleural pathologies like consolidation being present just below the pleura. Okay, at that time also you will have absent lung sliding, but that does not mount to the presence of pneumothorax. Okay, so that is the reason I told you lung point becomes more specific. Okay, but the specificity should always be combined with one or more findings. Okay, it should go in an order. So here there's a study which they did to find out a lot of what is the sensitivity and the specificity of each of the findings. So absent lung sliding, the specificity was as high as 100%, but the sensitivity is around 95%. But lung point, if you see, the sensitivity is very low. That is one of the most trickier operated related issue with diagnosis of pneumothorax. Okay, so most of the times in the chaos of whatever is happening, the ease of picking up a lung point will be very less. But having said that, the accuracy of that would be as high as 100%. Okay, so these are the things that you need to remember. So again, when we looked at the specificity and sensitivity, I earlier told you surgical cases more or less it will be okay because the patient would have come in with trauma. If you come to a medical ICU, then you see a lot of cases with consolidation and community or hospital acquired pneumonia, the sensitivity of the lung sliding and the specificity also falls short. Okay, so this is one thing that you need to remember. So coming to B lines, earlier we spoke about the bright, long, ray-like lines which arise from the pleura goes to the end of the screen, which usually cuts across the horizontal A lines, correct? These are vertical lines. So how do they progress whenever we have B lines? They usually are categorized into two types. Okay, there are static B lines and the dynamic B lines. Okay, what do I mean by static B lines? They are B lines in the absence of lung sliding. Okay, so I've given you a lot of examples of absent lung sliding earlier on. Okay, so whenever you have static B lines, and you have dynamic B lines, you need to look at when the lines are moving, especially in a normal lung, or else in a patient with pneumonia where the unaffected part of the lung will show you some presence of B lines. Okay, or else if the patient is developing pulmonary edema when you're giving a fluid resuscitation and you're assessing the patient for volume responsiveness. So in all these cases, you look at dynamic B lines. Okay, so why does this become important? Because there are certain nomenclatures which they have mentioned. Okay, so whenever someone asks you what is a lung rocket, so you need to remember that lung rockets are static B lines, especially which are noticed in the patient having absence of lung sliding. Okay, so this can be in a patient with a very bad ARDS. Okay, so these are B lines which are present when a patient's lung sliding is absent. Okay, so Absent lung sliding and presence of B lines, you can call that B line as a lung rocket. Okay, multiple lung rockets indicates probability of a severe consolidation with pulmonary edema. Okay, so B lines are nothing but a comet tail artifact, like I've already mentioned to you earlier. Okay, so they are usually present because there will be some amount of gas and fluid which will get mixed together, and whenever air enters this alveoli, there will be some amount of bubbling which is seen. Okay, that bubbling is what you see in the screen as a bright line, and that cuts across the A lines. Okay, that is your interlobular septum. Okay. So coming to interstitial syndrome, so here we see an image wherein you can see some air bronchograms, you can see pleural effusion, you can see lung and the liver. So what is this view? Which part of the lung? Which point? Come on, guys, I've already given the answer already. It's a Plaps point.
Flaps
Okay, so
point.
yeah, excellent. Okay, it's the right Plaps point. So you see here how many pathologies we could pick up here. Okay, so excel some B lines, we are seeing air bronchograms, we are looking at consolidation, we are also looking at pleural effusion. Okay. So all of this gives us an idea about a lot of pathology, right? So that's the reason this point becomes more beneficial when we are trying to diagnose something very quickly. Okay. So usually, I told you earlier, 1 to 2 B lines in one intercostal space is acceptable, especially when it is present in the lower intercostal spaces. But whenever there are more than or equal to 3 B lines per rib interspace, it is usually pathological. Similarly, if you have B pattern, which is usually present in more than or equal to 2 lung zones bilaterally, okay? So left hemithorax 2, right hemithorax 2, totally more than 4. Okay, usually if you have it like this, then it is called as interstitial syndrome. Okay, presence of B pattern and more than or equal to 2 lung zones bilaterally is called a interstitial syndrome. Okay. So what usually happens is whenever you're looking at this, okay, it's a very beautiful image which usually compares the CT findings along with the lung ultrasound. Okay, so this is one of the advantages of lung ultrasound. Okay, you can also have a understanding of the CT image. Okay, so to know the depth of the problem. Earlier on, when you have B lines which are present, what usually is said is the distance between the 2 B lines, if it is present up to 7 millimeters, it is said to be B7 type of B lines. As in when the number of B lines increase, the distance between the 2 B lines starts coming down. So if the patient progresses from B7 to B3 type of B lines, then the presence of an interstitial syndrome is higher. Okay, so more B lines and less space between the B lines, worse are the amount of pulmonary edema which the patient is developing, and probably it correlates to ground glass opacification of the lung by and large, which can be seen on a CT. Okay, the correlation is if the patient gets converted from B7 type of a B light picture to a B3 type of a picture, the amount of ground glassing which can be anticipated if at all we do a CT for this patient would be higher. Okay, so this is about the B lines and interstitial syndrome. Okay, so how do they progress? When we are talking about consolidation or we are talking about pneumonia and ARDS, initially starts with multiple B lines, then they become confluent B lines, wherein the space between the 2 B lines come down. Usually, at this point in time, there might be subpleural consolidation, presence of shreds, etc. Over time, as the pneumonia worsens, you will have the stages of ARDS setting in that will cause dense consolidation to appear, and when there is a lot of hepatization can also end up in the lung, so that will almost look similar to the liver. Okay, so that is the reason it is called as hepatization of the lung. Okay, so these are few of the images which I've shared here. Okay, so on the left hand side you can see subpleural consolidation. So subpleural consolidation, this is the bigger image. Okay, here what you see here is you see 2 ribs here. Okay, below the rib there is nothing here, right here also. So this is the bat wing appearance if at all you see, but we cannot comment so because it is the curvilinear image acquisition. So when you have this, you see that the pleura here is discontinuous. You have the pleural line here, and there is absence of that white line here. Okay, and then you again have the pleural margin here, and you see some amount of lung sliding which is present here. Okay, so you can also see some B lines here. Okay, so here on the other hand, you see an hypoechoic or a black area, right? So this is nothing but the shred. Okay, shreds are subpleural consolidations which causes break in the pleural line. Okay, so whenever you have a break in the pleural line, that is why it is called a shred sign. Okay, it shreds the pleura. Okay, the continuity of the pleura is lost. Okay, so I earlier spoke about the timeline of what happens in the pneumonia, right? So if you are looking at this part of the thing, this is an image which shows hepatization of the lung here. Okay, if at all I had an image which is dynamic, we'll definitely see that the air bronchograms would also be absent. Probably the patient will have a very minimal dynamic air bronchogram in this particular picture. Okay, why that happens is because this part of the lung is completely hepatized, or aeration in this part is completely lost. That's why it looks like a tissue, more or less like the liver which is present below. Okay, so what is the arrow pointing out at here?
Pleural effusion.
Pleural effusion. Okay, so that's just something that we need to understand. So what is this?
It's a dynamic air bronchogram.
Mhm. Excellent. Where do you see dynamic air bronchogram? Why do you say it's dynamic air bronchogram?
So we can see the movement of
Mhm.
uh,
So what is the movement that you're looking at?
the opening and closing of alveoli.
Okay. So what is the movement here is usually the proximal bronchus is usually patent and the distal alveoli is filled with some fluid or consolidation. Okay. So what happens here is the movement what you see is air is trying to enter the alveoli, but it is not able to pass through it. Okay. So while expirating, it just goes back. So that is one which usually you see in consolidation. So what type of air bronchogram is usually seen in static? What is the pathology? Static air bronchogram?
Collapse.
Collapse
That's
atelectasis.
right.
Okay, good. So, do you know the types of dynamic air bronchogram? Okay, there are two. Okay, there is a linear air bronchogram and a dot-like air bronchogram, a dynamic air bronchogram. Just you need to remember that. Okay, nothing great in knowing them. Okay, but by and large, there's a lot of newer lung ultrasound pathologies which are coming based on the lung air bronchogram picture. Okay, they're also doing. Studies on extended lung ultrasound. Okay, when we're doing extended lung ultrasound, again, there will be usually a heterogeneous lung pathology which will be present, right? Some part of the lung will have consolidation, some part of the lung will have atelectasis. So, how do we differentiate? That is always a question that we have when we're looking at that. Correct. So, only dynamic versus static air bronchogram cannot give us an answer there. Okay. So, there are certain other protocols that they're looking at perfusion along with air bronchograms and the lung slide. Okay, along with that, there's a stepwise approach wherein we can tell that this part of the lung is consolidated, this part of the lung is atelectatic or collapse. Okay, so this is the reason that we need to know about air bronchograms. Okay, good. So this point is the collapse point I've already discussed earlier. Most of the pathologies from pleural effusion, consolidation, hemothorax, okay, or hydrothorax, a lot of things can be usually diagnosed at this particular point. Either the right or the left, it will help you understand what is the pathology. Okay, so as I've told you earlier, right side you have the liver, diaphragm, and the lung. Okay, along with the spine, and the left side you have the spleen, diaphragm, and the lung with the kidneys on either side. So what is this? There's a star there. Identify the star and the arrow. Come on, guys. What is that sign called? There are a lot of signs. Okay, we'll be ending up lung ultrasound soon, and then we'll be going about other part of the lung ultrasound quickly. Okay. So it's called a hematocrit sign. Okay, so you see there is some amount of debris which is collecting in the dependent part of the lung ultrasound. Okay, so whenever you have debris and the above part is anechoic, usually referring to effusion, usually we should think about presence of blood. Okay, it can be an exudate as well, but this sign particularly is called as the hematocrit sign. Okay, what is this? It's called as the sinusoidal sign. Okay, so it's in a linear image which propagates as based on the cardiac pulsations. Okay, what is this? It's the presence of a pleural effusion wherein you see a quadrilateral which is being drawn. Okay, so when you have effusion, what is usually seen as the quad sign. Okay, so here RS refers to rib shadows, and the pleura is written at as a parietal pleura and the visceral pleura. Okay. So this is an other sign which usually indicates the presence of pleural effusion. This is jellyfish sign, wherein there is pleural effusion, collapse of the underlying lung, and sometimes even atelectasis. It can also have some brighter areas which you can see here that might be even consolidation. Okay. So the next question would arise. We have been talking about B lines. We have been talking about pulmonary edema, and one of you, while we started, first thing you answered was, "What is the use of ultrasound is pulmonary edema?" So when you're talking about pulmonary edema, can we differentiate between cardiogenic pulmonary edema and non-cardiogenic cause of pulmonary edema using lung ultrasound? Okay. So, whenever you are thinking of cardiogenic pulmonary edema, you know the problem is with the heart, and the lung by and large is normal, right? So, whatever happens because of the pump failure in the heartbeat, the right heart or the left heart, the secondary effects would be borne by the lung per se. So, what will happen? Normal lung architecture would be still intact. So, usually it is caused due to volume overload status because of pump failure. Pleura will still remain smooth and intact. That is, the anatomy of the lung would still be normal. Okay, so lung slide will be normal. There will be no visible consolidation. But on the other hand, because of a long-standing failure, you can have bilateral pleural effusion. Coming to non-cardiogenic pulmonary edema, when you're looking at it, is usually the primary cause is the lung here. So whenever you have a lung pathology, you usually see there will be shred sign which is present. That is the irregular thickening or cut across, okay, margin, right? So you will see irregular pathologies of the pleura. Then you'll see consolidation. You might see B lines associated with decreased lung sliding. Okay, so what is this B lines with associated with decreased or absent lung slide called? Lung rockets. Okay, I think so. You're not paying attention. Okay, so lung pulse as the site of consolidation is another sign which we see in cardiogenic pulmonary edema. Okay, so with having said all of this, sometimes if at all there is fluid accumulated, it is also possible that they have pleural effusions. Okay, so that can be a pneumonic effusion. Okay? So bilateral pleural effusion usually is indicative of a cardiogenic cause, but having said that, it is not mandatory. Okay, but you should remember, in cardiogenic cause of pulmonary edema, the lung lung parenchyma, the lung architecture, and the anatomy would remain normal. Problem is the heart. When non-cardiogenic cause, usually we'll have all of this. Okay, so when I said about lung architecture being normal, at that time when we are suspecting of a cardiac etiology, do the echo as well. Okay, so if you find certain pointers for cardiac failure wherein you see an RWMA or a diastolic dysfunction, then you can think that this is definitely a cardiogenic cause of pulmonary edema. Okay, so this is how we differentiate between cardiogenic cause and non-cardiogenic cause of pulmonary edema using a lung ultrasound. Okay, so if they ask you a question like this is how you can answer this. Okay. So pleural effusion signs, we have discussed most of them. Okay, so jellyfish, plankton, most of them look alike. Okay, so when I'm talking to you about pleural effusion in the exam, whenever they give you a pleural effusion, okay, so the question they might ask is, how will you quantify a pleural effusion? Can anyone tell me how you quantify? Do you guys quantify your pleural effusions? Do we have to quantify? So I'll go to this slide here. Okay, so we'll take the hematocrit sign there. Okay, so for easier things, how do we quantify? Do you know any formulas? Yes. See, this is something that you're doing daily, I hope. I thought I'll have more answers and more interaction. Okay. So what we usually use is the Balix formula, which is very commonly used. Okay. Balix formula, usually the patient needs to be supine. Okay. And the head end elevation should be roughly around 15 to 30 degrees. Okay. The patient is placed at that position. At end expiration, you need to place the probe cephalocordate. Okay, perpendicular to the dorsolateral chest wall. Okay, and then you have a measurement between the visceral pleura and the parietal pleura. Okay, so you just draw a line here, and then based on that, sorry. So when you draw a line between the two pleural margins, that is the lung margin and the parietal pleura. Okay, so lung margin usually corresponds to the visceral pleura. If you're taking it here, it will be between the parietal pleura and the visceral pleura. It will be easier here in the quad sign picture. Okay, so between these two, if you take the measurement in millimeters, okay, when the patient is at end expiratory position in a semi-recumbent position, okay, so these two are very mandatory. Okay, end expiration, head end elevation of around 15 to 30 degrees, and that time if you multiply this number, which is calculated in millimeters, into 20, you will get the value in ml. Okay, so that roughly corresponds to the volume of pleural effusion. Okay, so this is Balix formula. There are multiple other formulas that you can just remember the names. Okay, so Einberger's formula, Gwocki's formula, etc. Okay, so please learn at least Balix formula, because most of us everywhere use Balix formula when we are calculating pleural effusion. Okay, so this is about pleural effusion. So coming to the protocolized approach in lung ultrasound. Okay, so can you name few of the lung ultrasound protocols that you guys follow? Okay. For acute respiratory failure, we have the blue protocol. For the shock, we have the false protocol. Okay. There are other protocols like Lucy, etc. Lucy actually was given by Daniel Lichtenstein. Actually, Daniel Lichtenstein is a key figure who actually has written a lot of papers, and he is, I think so, considered as the father of lung ultrasound as well, because the landmark papers on lung ultrasound have come from him. So he actually described lung ultrasound as Lucy, lung ultrasound in critically ill patients. Okay, so there are a lot of protocols which are present. Why do we have to use a protocol? Usually it will go in a systematic fashion and the margin of error would be reduced. So if we use this, we'll be able to get better results and we'll be able to identify the pathology at the earliest. Okay. So in weaning, we use another protocol called as the ABCDE approach. Okay, that is usually going to combine both the echo as well as the lung ultrasound, which I'll be dealing in the last part of the talk on lung ultrasound. So can anyone do the match the following? Are you guys willing to unmute and answer? So if you unmute and answer, then I'll be able to go ahead with blue protocol and then go ahead with weaning. Okay, otherwise it will be quite monotonous. Okay. Since you guys are not answering, I'll just directly go to the answer of blue protocol. What we usually see in blue protocol is we have categorized them into A profile, B profile, or AB profile. Okay. Based on this, we can also come to a diagnosis of a DVT. Okay. So that is one of the things that you need to look at. That is why it is called as the A DVT profile. Similarly, we have a B dash profile as well, and an A dash profile. Okay, so what do we mean by A profile? A profile refers to anterior lung sliding present, A lines are present with veins being free. Okay, so usually A profile refers to a probable exacerbation of a COPD or a severe asthma which is present there. Okay, so this is what we see in the blue protocol. So usually it rules out the presence of a pulmonary edema. Okay, so if the patient comes with respiratory distress and the patient is asthmatic, this is what we can anticipate in the lung ultrasound. Okay, so if the patient comes with exacerbation of COPD, then you see an AB profile. Probably one half of the lung is A profile, another half of the lung is B profile. So that time you can think as an infective exacerbation of a COPD. So that is called as an AB profile. Okay, so B profile, I have told you earlier, there can be lung sliding with the presence of lung rockets. That usually indicates the presence of pulmonary edema. Okay, so it can be cardiogenic, it can be non-cardiogenic. So there's a lot of other profiles which I've earlier mentioned. B dash profile usually refers to the presence of a B profile, that is pulmonary edema with absent lung sliding. Okay, so if lung sliding is present, then it is B profile. If lung sliding is absent and the B profile is present, then it is a B dash profile. So usually lung rockets will be present at that particular time as well. Okay, so C profile refers to anterior lung consolidation. PLAPS usually refers to presence of pneumonia, wherein you can see a profile, presence of free veins, and probably consolidation as well. Okay, DVT profile usually you see in pulmonary embolism, wherein I mentioned earlier on, wherein you'll have a profile in the lung. What usually happens is pulmonary oligemia, which sets in pulmonary embolism. Correct. What is pulmonary oligemia? The blood supply would be down because of obstructive shock. Because there is obstructive shock, the probability of the patient developing pulmonary edema is still on the lower hand. Okay, it's the right-sided pathology, right? So there will be back pressure problems, but having said that, you will not see any presence of B lines at that time. Okay, so in that cases, you see a profile, and when you do a DVT scan, like a compression ultrasound, if you see the presence of a deep vein thrombus, then it is indicative of a pulmonary embolism. So that is referred to as DAVT, a DVT profile. I'm sorry. Okay. So A dash profile is A profile with abolished lung sliding, wherein you also see a lung point. So I told you earlier, presence of B lines, think of alternate pathology in the absence of lung sliding. So if you see absent lung sliding, A profile being present and a lung point present, then it is labeled as A dash profile, and then the diagnosis would be pneumothorax. So if you're writing your lung ultrasound finding in a chart, if you just mention it as A dash profile, then it is indicative of pneumothorax. Okay, so this is by and large the nomenclature of the blue protocol. Okay, so how do we approach to a blue protocol? Make sure that the patient is in a semi-recumbent position. Use a curvilinear probe, set the depth around 6 to 10 centimeter with the pointer in cephalocaudate direction, that is the longitudinal view. Okay, and the pointer being cephalad. Three regions should be scanned. Okay, remember that is very important. Semi-recumbent, curvilinear probe, cephalocaudate, 6 to 10 centimeter depth set. Okay, and these are the basic primary settings on the ultrasound machine. After that, three areas you have to scan on each side. Okay, so totally six regions will be scanned. So hemithorax left, upper anterior and flaps point, hemithorax right, upper anterior and flaps point. Okay, so these totally six regions will be scanned in blue protocol. So what do you look for when you're scanning? You look for the lung slide, you look for the A lines, the B lines, and the presence of consolidation. If you have acquired these images, then you can come to a proper diagnosis using the blue protocol. So how does it go? Starts with the lung sliding. Okay, so usually if lung sliding is present and there is B profile, that is an indication of pulmonary edema. If lung sliding is present and there is A profile, then you have to do a sequential venous analysis. That is, you have to look for the presence of a deep vein thrombus. Okay, so if you have a DVT scan which is positive, probably that can be an indication of pulmonary embolism. So lung sliding present, A profile. Okay, whereas you can think of a pulmonary oligemia, compression ultrasound showing DVT, that is pulmonary embolism. But if you feel that the veins are free, then you look at the PLAPS point. If the PLAPS point is showing some consolidation, then it is pneumonia. Okay, if it is not showing anything, then just a acute exacerbation of a COPD or asthma. Okay, so in COPD and asthma, still you can see A profile and you can see lung sliding which is being present. Pneumonia, if it is a very small pneumonia, then also you can see lung sliding with A profile, wherein B profile need not be present. Okay, so this is also a possibility. Most important differentiating point here that A profile is the presence or absence of the deep vein thrombus. Okay, so that is one thing you have to remember. Coming to the middle part of the blue protocol, you can have a B or a B or a C profile. In these cases, probably the thing would be pneumonia. B dash profile, as I've already mentioned to you earlier, that is your absence lung sliding with a B profile. That is again an indication of pneumonia. Sometimes when you have an abolished lung sliding, wherein you have an A dash profile. Okay, so absent lung sliding, A profile which is present, and then you have a point which is positive, then it is an indication of pneumothorax. But if you don't have a lung point, then you need to look at other possibilities wherein you might have to call for an X-ray, or you might have to wheel the patient for a CT thorax. Okay, so this is by and large the blue protocol, which is usually used for acute respiratory failure. Okay, the things that you have to look at for is B profile, A B or C profile, B dash profile, and A dash profile. Okay, so A dash profile, you need to think about pneumothorax. Okay, so that is one thing that we need to remember. Okay. Coming to false protocol is an emergency protocol usually used for any shock states. Okay, so especially it involves the heart and the lung scans together. Okay, so this will be able to understand what is the cause of the shock, and will be able to come to a diagnosis at the earliest. So this is a schematic decision tree, like as we saw earlier for the blue protocol, what we do in acute circulatory failure or shock state. Okay. So firstly, you do a cardiac sonography, rule out the presence of a tamponade or a pulmonary embolism. Okay. There are a lot of signs. I think so. We have already mentioned to you earlier when we spoke about pulmonary embolism, from the McConnell sign to the 60-60 sign, etc. When you're talking about cardiac tamponade, there is something called as a diastolic collapse with presence of a fluid in the pericardial space. Okay, so this is something which is an indication for uh, cardiac tamponade. Okay, so if that is present, then definitely that is the cause, and then it is obstructive type of a pathology, and that has to be dealt with. So this is about the cardiac origin issues, okay, or the cardiopulmonary problem. So if you're thinking of pulmonary embolism, definitely you know probably the tricuspid regurgitation would be higher. Okay, so at that point in time, your TAPC also would be changed. So if it is going below, then it is an indication of an RV strain. Okay, all of that also can be seen, but you will not have much time. Therein, you have to rule out these two pathologies, tamponade and pulmonary embolism. If you have ruled out this, if you feel that still there is a probability of an obstructive shock, then you have to do a lung ultrasound based on the blue protocol. What do you look for? You need to look for the A dash profile, that is the presence of a pneumothorax, absent lung sliding, A profile, and presence of lung slide with M mode showing stratosphere sign. With all of this, if you find out, then it is a probability of pneumothorax. And because there is pneumothorax and there is shock, it becomes a tension pneumothorax, and that cause of the shock is obstructive shock. Okay, so if this is set and you've got the diagnosis, you can treat accordingly by the insertion of an ICD or a catheter for a tamponade, and for thrombolysis for pulmonary embolism. If you go ahead, if you none of this is noticed, if everything comes out to be normal, you still see some amount of B lines which is present, then you have an A profile or an AB profile, then you have to look at the cardiac status. At that particular time, if you see there is RWMA or there is regional wall motion with some regurgitation or some other etiology, you can look at the ECG as well at that time. Then probably the cause would be cardiogenic shock. Okay, so at that particular time, if you still feel that there is no RWMA, but the patient is still in shock, okay, then you need to think about fluid resuscitation, which is still ongoing when the patient has come in with acute circulatory failure. And based on the fluid therapy in all these timelines which is going on, if you see that the patient has benefited from that, then the patient probably is a case of a hypovolemic shock or a hemorrhagic shock. Okay, so fluid therapy, clinical improvement, then it is probability of that patient having hypovolemic shock. But during fluid therapy, in all these processes, if the patient develops B profile, then patient does not have any active collection anywhere based on your EFAS scan, then probably it is a distributive shock, that is your septic shock. Okay, so this is how we usually go about false protocol. There is whenever someone asks you what is a false protocol, it is a protocol for acute circulatory failure which is a four-step process. The four steps involves ruling out of these particular shock in order. Firstly, the step one, we need to rule out obstructive shock. Step two, we need to rule out cardiogenic shock. Step three, you need to rule out hypovolemic shock. Step four, we have to come to a conclusion that it is a probable septic shock, okay, or a distributive shock. Okay, so this is how you need to answer what is false protocol. Okay, so this is by and large about blue protocol and false protocol, especially which involves lung ultrasound and cardiac scan. Okay, coming to the use of lung ultrasound and weaning. Okay, so name the tools of assessment which are used for liberation of weaning in lung ultrasound. What are these? Guys, previous batch they had answered a lot of these questions when we asked them. Can you identify the images? Okay, it refers to diaphragmatic excursion, lung aeration score, etc. Okay, these are the tools which we usually use in lung ultrasound. So, what are the tools that can be used apart from lung ultrasound and weaning? Any other thing that we use apart from lung ultrasound? So, weaning from mechanical ventilation, if you're looking, do you look only at lung ultrasound or something else along with it? Almost to the answer. You also look at the cardiac ultrasound, okay, the echo as well. So, what is lung aeration score? I mentioned earlier, lung aeration score is a score which gives us an idea as the amount of lung which is recovered, or on the contrary, you can also look at it like how much lung is still affected. Okay, so earlier on, I mentioned about 6 quadrants on each hemithorax, right? So there'll be 12 quadrants in total, correct? So when you're looking at this on the whole, each quadrant will be scored. Okay, so based on this score, we can have an idea whether this patient is fit for weaning or extubation. Okay, so there's a lot of research which is going on, in successful weaning from mechanical ventilation based on an objective criteria. Okay, earlier on there were a lot of tests like your RSBI. Okay, so objective criteria, subjective criteria, etc. But still, there is no foolproof way to getting an idea that this patient is not going to fail extubation, correct? So, in that sense, when you have to know the readiness for extubation, these scores or these tools of lung ultrasound will come in handy. Okay. So, I mentioned earlier we have 12 quadrants that we have to look into, and we need to score each quadrant based on the pathology. So the scores range from 0 to 3. Okay, so 0 being the best part and 3 being the worst score which is possible. So score 0 refers to the normal lung ultrasound wherein you'll have the A pattern, but slowly in one you see presence of a B line, right? Usually presence of more than or equal to 3 B lines per area of examination is usually an indication of score 1. In the same way, if you have P lines covering more than 50% of the screen without any subpleural alterations, then it comes under score 2. If there is a lot of consolidation along with B lines which is present, and air bronchogram is also visible, that usually refers to score of 3. Okay, so consolidation, there is no ambiguity, score of 3. Normal AA scan will give you a score of 0. Anything in between, it will be 1 and 2. So minimal B lines between 3 to 5 probably is score 1. If you have a confluent B line picture, then it is score 2. Okay. So this is by and large about the lung aeration score. So I told you this is going to be categorized as the anterior chest wall, lateral, and the posterior. Okay. So including all of them, you will have roughly how much? Right lung, left lung. Okay, totally you have 18 on each side, so totally 36. Okay, so roughly when you have 36 as the number, what they have usually found as if there is a lung ultrasound score of less than 11, it is an excellent score. Okay, the patient can be extubated with the accuracy level of more than 90-95%. But if the lung ultrasound or the lung aeration score is more than 70, then it is highly predictive of post-extubation distress and extubation failure. So remember, the number between 11 and 13 is a better predictor for readiness of weaning and weaning success. When you see the lung aeration score being more than 17, it is highly predictive of extubation failure. Okay, so this is about lung aeration score. So coming to the respiratory muscle ultrasound, so there are a lot of techniques when we speak about respiratory muscle ultrasound. Okay, it can majorly what studies have been done of lately, and there is good amount of evidence is for the diaphragmatic ultrasound. But having said that, there's a lot of research which has already gone into intercostal muscle pathologies and intercostal muscle imaging as well. Okay, so by and large, we look at these two things. But today I'm going to discuss mostly about the diaphragmatic ultrasound. Okay, so diaphragmatic ultrasound, we need to know few things. Okay, we should know what are the tools we are using, what is the type of probe which you use for a particular type of diaphragmatic examination. Okay, so you need to know whether you have to use a curvilinear probe or you need to use a linear probe. Where do you have to place the probe? How do you have to place the probe? How does the patient have to be? What are the prerequisites? All of this has to be remembered when you're doing a diaphragmatic ultrasound. Okay, so one thing when you're looking at diaphragmatic ultrasound and weaning as general, you need to understand what is wipe or WIPO. What is wipe or WIPO? Can anyone expand this? Wipe, WIPE. So WIPE is actually an acronym for weaning induced pulmonary edema. Okay, so I'll be discussing these things in the further slides. Okay, so these are the questions that they might ask you in your examination. Okay, so firstly, you need to know the prerequisites. Usually the diaphragmatic ultrasound is done on a patient who is spontaneously breathing. Okay, and they're ready for weaning. Okay, so mostly if the patient is on a lot of ventilatory support, especially with a high PEEP, assessment of diaphragmatic ultrasound would not be optimal. Okay, so make sure that the patient is at least on a TPs, or if the patient is able to tolerate a minimum CPAP, that should be good enough. And along with this, if the patient is neurologically stable and is able to follow commands, then it will have a better outcome as well in assessment for diaphragmatic function. So what we need to remember is there is a B mode and the M mode, right? B mode, I told you earlier, is the brightness mode, and M mode refers to the motion mode. In diaphragmatic ultrasound, mostly what we usually use is the B mode for identifying the structures and the M mode for the assessment of the function. Okay, so you have to know both of them. Okay, so the patient usually has to be in a semi-recumbent position, the best even in supine position. Lot of cutoffs are based on the position. Okay, whenever we're looking at cutoffs, it is based on the position where we are measuring. Okay, so you need to measure this in something called as the zone of apposition. Okay, so you see the image here, which on the right side we have a pointer measuring the zone of apposition. Zone of apposition refers to the point where the rib cage meets the thorax. Okay, so the diaphragm and the rib cage, wherever it meets here. Okay, these two things together, they form the zone of apposition. The point where the rib cage meets the diaphragm. Okay, that is called as the zone of apposition. So when do we measure it? We measure it in two places, that is during end expiration and end inspiration. Okay, so both these things or the phases of the respiratory cycle is mandatory for us to know the assessment of diaphragmatic ultrasound. Okay, so there are different tests that we do in diaphragmatic ultrasound. I'll be dealing with that in the later stage, but here let us understand the anatomy related to diaphragmatic ultrasound. Okay, so here I've taken the the right-sided images. Here you can see the liver below and the lung above. Okay, then we see the chest wall, and then we see the diaphragm. Okay, so diaphragm is, there are two things that we need to remember here. Okay, the one which is usually facing the peritoneum is usually brighter. Okay, the diaphragm part of that. Okay, whereas the one part of the diaphragm which is towards the pleura is hypoechoic. Okay, so it will not be well delineated. The only thing is, you should remember there are two lines which are going to be horizontally be present, and between the two lines there is another fibrous layer which runs across, and that fibrous layer is the neurovascular bundle. Okay, so this is how we identify the diaphragm when we are looking at the ultrasound image. Okay, so again, there are both the probes that are used, that is both your linear probe as well as your curvilinear probe, that I'll be discussing in the next slide. Okay. So coming to how do we go about performing the diaphragmatic ultrasound. So there are two things that we have to look in. Okay, two functions. One is the diaphragmatic thickness fraction. Okay, and the other is the diaphragmatic excursion. So earlier I told you one thing: the depth is better acquired using a curvilinear probe, right? So whenever you're using a curvilinear probe, as we see in image A, then we measure the diaphragmatic excursion, as you can see in image C. Okay, so how does it? How will it be performed? Usually, you have to put a B mode, identify the structures, that is your liver, diaphragm, and the lung. Okay, and the curvilinear probe has to be placed in between the anterior axillary line and the mid axillary line. Okay, and the curvilinear probe will be placed in a horizontal fashion. Okay, so in the subcostal margin from the anterior axillary line to the mid axillary line, if you move across, then you will be able to identify these structures. That is your liver, diaphragm, and the lung in the B mode. Okay. So once you're able to get this imaging, then you have to run the M mode or your motion mode. Okay. So in when you run the motion mode, then you need to look at what is happening to the diaphragm. Okay. I told you earlier, diaphragm will appear like a bright white line. Correct. So if you do a deeper imaging, then you'll be able to delineate the layers like the parietal part and the pleural part and the neurovascular bundle. But because it's a curvilinear probe, the image accuracy goes down, and because of that, all that we can see is the movement of the diaphragm. That's it. So that's why it is used for diaphragmatic excursion. So we see the diaphragmatic excursion in three phases. One is QB, that is your quiet breathing. Okay. Then we see DB, that is your deep breathing, and then we ask the patient to do a sniff. Okay, that is a ventilatory sniff or a voluntary sniff. Okay, you can ask them to do that and then look at how the diaphragm responds to that particular command. Okay, there are certain cutoffs that we need to look into, and based on that, we can come to a conclusion whether this patient is fit for extubation or not. Okay, so this is about diaphragmatic excursion. So the probe is supposed to be horizontally placed. It's a curvilinear probe between the anterior axillary line and the mid axillary line and the subcostal margin. Okay, remember these are the landmark points for diaphragmatic excursion. Okay, so coming to the next part, what we see, we have to do the B mode. When you're getting this, when you do the B mode, identify liver, diaphragm, and the lung. After you identify the liver, diaphragm, and the lung, diaphragm appears like a bright white line. So when you have the bright white line present and it is moving with each phase of respiration, apply the M mode. So when you apply the M mode, you can easily delineate between the diaphragm and the other structures, because the diaphragm is the one which moves with the cycle of respiration. Okay, along with the other structures as well as the like liver also. But because it's bright at that particular junction, you can ask the patient to do a deep breathing. Okay, so when you have that, you can see the movement across, and then you can categorize as quiet breathing, deep breathing in a voluntary sniff position. Okay, and then there are certain cutoffs which I'll be discussing in the next slide. So this is about diaphragmatic excursion. After this, we'll be discussing about diaphragmatic thickness fraction. Okay, so this is another modality which is used for weaning processes. Okay, or it is a part of the diaphragmatic ultrasound. So here, what we usually use is the linear transducer. Okay, this linear transducer is usually a high frequency probe, right? Which is usually used for vascular structures. So high frequency, I told you earlier, picks up better image quality. And because it picks up better image quality, you will be able to see chest wall and the diaphragm better in the B mode. Okay, it is again in the zone of the apposition, which is the zone of apposition is where the diaphragm meets the rib cage, right? So that is the chest wall and the diaphragm area. So when you have this, you have to place the probe in a vertical fashion. Okay, cephalochordate fashion. Remember, For excursion, it is in a horizontal fashion, curvilinear growth. In diaphragmatic thickness fraction, it is the linear probe in a cephalocaudate direction in the zone of apposition. Okay, so when we get this thing set, then you run the M mode, and then we look at the thickness fraction based on inspiration and expiratory cycles. Okay, and then we derive a ratio called as the diaphragmatic thickness fraction. Okay, I'll be discussing in the next slide. So these two are the things that you need to remember. Okay, so I hope I'm clear in these things, and you guys have understood the nuances associated with the two modalities of diaphragmatic ultrasound, that is excursion and thickness fraction. Okay, so remember, whenever someone asks you a question, you need to know these things. Okay, what is the probe, where do you place it, what is the prerequisite, and what are the things that you need to look at. Okay, so I told you this earlier as well. I'm going to repeat so that you know it. So mid-clavicular line, anterior axillary line, then you move it across from the anterior axillary line to the mid-axillary line as well. Okay, so here, whenever you're moving, depends on the patient's body habitus. Okay, so earlier on, I remember that I told you here the image looks like anterior axillary line here, and the subcostal margin coming here. Okay, so this is actually the anterior axillary line, posterior axillary line, and the mid-clavicular line. So you start from the subcostal margin, from the mid-clavicular line, anterior axillary line, and then you go across to the posterior axillary line, wherein you get the diaphragm, liver, and the lung picture accurately. Okay, so when you get that accuracy, then you need to do the M mode and then get the excursion. Okay, so that is the diaphragmatic excursion. So how does it happen? It is in between the phase of inspiration and expiration, and then we do a certain cutoffs. Okay, so whenever we get this and do a measurement between the inspiratory phase and the expiratory phase, if the diaphragmatic excursion is less than 10 millimeters, then more often there we can come to a conclusion that this patient has diaphragmatic dysfunction, or the probability of this patient failing weaning would be very high. Okay, so there's some pathology which is present, which is causing the movement of the diaphragm to have reduced. It can be atrophy, it can be critical illness neuropathy, it can be a palsy, etc. Okay, so whenever you have a palsy like picture also, you can see that the diaphragmatic excursion would have come down. Okay, so if it is more than 10 millimeters, or what they say cutoff is 1.1 centimeters. Okay, if it is more than that, probably it is normal. If it is less than 10 millimeters, definitely it is indication of diaphragmatic dysfunction. Okay, so the next part I told you is in the zone of apposition. We use a linear probe in a cephalocaudate direction in the anterior axillary line. And the anterior axillary line, when you're looking at, we look at the chest wall and the diaphragm. And here we do two readings. Okay, so one is in the end inspiratory time, end expiratory time. Okay, so we look at the diaphragmatic thickness at that particular time. Okay, so the diaphragmatic thickness fraction is calculated as the fraction of the diaphragm in the end inspiratory minus the end expiratory time divided by the end expiratory time. Okay, if this thickness fraction is less than 20, definitely it is indication of failure. 20 to 36 is a gray area. Anything more than 36 is a best value. Okay, so this is how they usually look at. Okay, so the healthy subjects and the abnormal subjects. Okay, you see here when you ask them to do a sniff, especially when you're doing the excursion. So there's a very good sniff here, and the diaphragmatic movement is very good. Okay, so on the contrary, when you're asking them to take a breath here, it actually goes down. So this usually is a paradoxical movement of the diaphragm, which indicates an abnormal function, which is going to cause the diaphragmatic dysfunction. Okay, this is about excursion. Okay, so again, coming back to diaphragmatic thickness fraction. So this thickness fraction, there are a lot of cutoffs which is based on the positioning. I told you earlier, less than 20 definitely is indication of poor outcomes. More than 36 is a good outcome. 20 to 36 is a probable plus or minus, correct? So that's something that you guys have to remember. Okay, so if you have not remembered any of those values before, if you're looking at this table, this is the take home thing that you can remember. Okay. So what do you have to look at? You have to look at the diaphragmatic excursion earlier. If it is less than 1 centimeter or 10 millimeters, there is a diagnosis of diaphragmatic dysfunction. Okay. If the thickness fraction is less than 20, definitely there is diaphragmatic dysfunction. Along with this, there is a lot of other functional diaphragmatic assessment which is going on. Okay. Like they use tissue Doppler imaging, speckled ultrasound of the diaphragm. Okay, all of this is being done just to find out what is the functional assessment of the diaphragm. Okay, so these can add on to the earlier two modalities, that is your excursion and thickness fraction, for the diagnosis of diaphragmatic dysfunction. Okay, so along with whatever I mentioned earlier, that is your tissue Doppler imaging of the diaphragm, along with speckle tracking ultrasound, there is another thing called as the shear wave elastography as well. Okay, so all of them helps us understand the overall functionality of the diaphragm and the probability of weaning these patients successfully on the ventilator. But still, these are under a lot of clinical trials, so to put them into daily routine bedside use is still kind of difficult. Okay, so earlier on, I mentioned to you something called as weaning-induced pulmonary edema. All this while we were talking about lung and lung alone, along with diaphragm. But totally we forgot that the patient, when we are extubating or weaning him from ventilation, there will be a switch from positive pressure ventilation to negative pressure ventilation, and there will be some sort of heart-lung interactions. So whenever there are heart-lung interactions, if one of the two are not optimally present, then there will be a higher chances of development of pulmonary edema. Okay, because one, the heart must be able to take the additional preload which comes in at the time of extubation, and if the heart is unable to take the excessive stress, then there will be development of pulmonary edema. Okay, so that is called as weaning induced pulmonary edema. How do we diagnose that? Usually we have to do a tissue Doppler imaging, especially in the mitral valve area, and if the E by E prime value is less than or equal to 8, it is consistent with the pulmonary artery occlusion pressure being less than 18. That is a normal cardiac function. Okay, so whenever you have an E by E prime ratios which are usually more than 10 or 11, so probably the patient's propensity to develop cardiogenic pulmonary edema would go higher, and when they develop it at the time of extubation, then these patients will be considered to have developed weaning-induced pulmonary edema. Okay, remember lung ultrasound associated with cardiac dysfunction. If there is cardiac dysfunction and your E by E prime values are going higher up, so that time you might have to consider the probability of development of weaning-induced pulmonary edema. If the E by E prime value is less than 8, it is roughly going to show that the pulmonary artery occlusion pressure is going to be less than or equal to 18, which is the normal value. Okay, so probably at that time the patient might not develop a VIPO, okay, or VIPE. So coming to the last part of the lung ultrasound, what is the role of POCUS or point of care ultrasound in weaning failure? The thing I've already mentioned to you earlier, it is the ABCDE approach. Okay, so usually A stands for the aeration score, right? I told you this is a score of 36, right? Anything less than 13 is a better outcome. Anything between 11 to 13 is what they say. Okay, less than 11, definitely a great number. More than 17, be ready that this patient can have a high risk of weaning failure. Earlier on, I mentioned to you about Balik's equation. So if at all you're looking at pleural effusion, which is present when you're doing the lung ultrasound, know if this has to be drained. Okay, so if there is a moderate to severe pleural effusion, this might be one of the reasons that the patient might fail weaning. Okay, so this can be estimated using the Balik's formula, which I've already mentioned to you earlier. Semi-recumbent, 15-degree head-up position, and expiration, perpendicularly placed probe in the dorsolateral chest wall. Okay, at the end point of expiration, if you measure the distance between the parietal and the visceral pleura and in millimeters and multiply it into 20, you'll get the value in milliliters. Okay, so that will be the amount of pleural effusion which is present. So this is about the A part of the ABCD approach in focus for weaning finger. Coming to B again, below the diaphragm, we looked at above the diaphragm, that is pleural effusion. So below the diaphragm, look for the probability of any collection like ascites or hepatic abscess or renal abscesses, etc., which can be causing hindrance to the diaphragm. Okay, so that can cause a diaphragmatic irritation, and because of which the respiratory mechanics can get altered, and that can also cause some sort of weaning failure. Coming to the cardiac causes, I've already mentioned to you earlier, assess the LV function. Both systolic and diastolic function has to be ascertained. Okay, so routine basic, cardiac ecography has to be done. Okay, so look at both the LV and the RV. Okay, and look at the E by E prime ratio that I've already mentioned to you earlier. If you feel that it is less than or equal to 8, then okay. More than 10, 12, then definitely there is an indication or a propensity for these patients to develop vening induced pulmonary edema, and that can cause failure. Okay, so this is C part of the thing. Next we have the diaphragm again to revise two main things. If you remember, it's more than enough. Okay, so firstly, remember diaphragmatic excursion. So when you're doing excursion, you have to remember it's a curvilinear probe, subcostal margin, midclavicular, anterior axillary, posterior mid axillary line. Okay, so you need to scan between this in the B mode. Okay, and then find the liver, diaphragm, lung area. Okay, in the zone of apposition, and then do the M mode. Okay, and the M mode, if it is less than 10, it is a bad thing. Okay, if it is more than 10, the probability of success is higher. Okay, the excursion. Then next one would be thickness fraction. Okay, so thickness fraction, again you have to do inspiratory minus expiratory divided by expiratory. If the thickness fraction is less than 20%, then the risk of failure is higher. If it's more than 36%, they say the success of winning is higher. So apart from this, I've told you earlier, there are a lot of newer imaging in the lung which is coming up. Okay, especially for diaphragm, if it is there. I spoke to you about this speckled ultrasound, shear wave elastography, along with the tissue Doppler imaging. Similarly, there is intercostal muscle, ultrasound also, which is present. So that is still a lot of studies are going on. Widespread protocolized approach for that is still not available. Okay, so this is about D part of it. Remember, E stands for extra diaphragmatic respiratory muscles, which I already spoke to you. That is your intercostal muscles, scalene muscles. Okay, all of this can be looked into for the probability of weaning failure. Okay, probably if there is an abscess sitting somewhere. Okay, or if there is a subpleural consolidation which is present in the anterior part of the chest. Okay, all of these can cause some issues. Along with this, obviously, long-standing patients who has developed diaphragmatic atrophy can also develop critical illness, neuropathy, and muscle fatigue and all of that. So that can also be a cause for weaning induced pulmonary edema, and in the long run it can also cause weaning failure. Okay, so these are the things. This is the systematic approach of weaning using ultrasound. Okay, so that is aeration below the diaphragm, cardiac, diaphragm per se, extra diaphragmatic respiratory muscles. Okay, so this is about the lung ultrasound and the diaphragmatic ultrasound in general. Okay, so whenever you are talking and if they ask you a question as to how would you use it only for weaning, what you can do is you can start by telling that you can do a routine spontaneous breathing trials. Once the patient is on spontaneous breathing trials, make sure that the patient is able to follow commands. Probably minimal CPAP is also sufficient, probably 5 centimeters of water, up to that you can go. And then look at your both echo parameters and the lung parameters. Okay, so based on these echo and lung parameters, you can predict the extubation success in these patients. Okay, off lately, along with the things which I mentioned to you earlier about diaphragm, that is your diaphragmatic thickness and excursion, there is something called as DRSBI, that is your rapid shallow breathing index, along with the diaphragmatic excursion. So they say that if you have a ratio, that how it is measured is usually it is the SBT which is taken, which is divided by the RSBI. Okay, so diaphragmatic excursion by that. So if the DRSBI is less than 1.6 breaths per minute per millimeter at 30 minutes, okay, it usually is an indicator of better accuracy for weaning success. So remember, diaphragmatic RSBI less than 1.6 breaths per minute per millimeter at the end of 30 minutes shows a better indication for weaning success. Okay, so these are something like a newer addition, so you can add on, you can read about it in the reference articles, I think. So I recently came across article in the 2025 update as well, which has a good deal of information on lung ultrasound, okay, in the respiratory part. So you can read up from there as well, along with whatever we have given you in the articles. Any questions? I'll be happy to take before I do the next thing, which is a small class. Rageshi, is there any other questions they're asking?
No, sir, there is no question in the chat box.
Okay. So coming to the second topic of the day, that is subphenotype of ARDS. This is something that we went through to look at what are the newer topics which are, probably questions that they can ask. Of lately, especially after the COVID pandemic that has come across, we looked at newer definition of ARDS, especially in terms of management. Okay, so when they came across that, we looked at H type, L type, etc., wherein the phenotypic classification of ARDS was coming across. So because of this, in the recent critical care journals as well as the update books in the national conference as well, a lot of talks on phenotypic classification of ARDS has come across. So this is why I thought we'll just give you a brief update about this. Please go back and read about it. Okay, so if a question is asked, I'm just going to skim the basic headings under which you can ask. Okay, this will not be a major question to you, but at least you should understand why they are focusing on these topics of lately. Okay, so we know very well that the diagnosis of ARDS, the criteria has been changing from time immemorial, especially when after Ashford diagnosed it way earlier, and then after 20, 40 years in 94, the ACC committee came across, and then the first definition of ARDS was given. And after that, they still felt there were some shortages, and they changed the definition in 2012 in the Berlin's criteria. After that, again, off lately, you know that the new global definition for ARDS has also come across. So why do you think that every 2 decades there is an update, or every 3 decades there is an update? And recently, so in just within 10 years, we have another definition for ARDS. Majorly, it's because the diagnostic modalities are improving, and the number of cases are improving, and the experience is improving. So we are focusing on ARDS itself as a phenotype. Okay, we have to always remember ARDS is actually a syndrome, not a disease per se. Okay, so it is probable that the diagnostic approach is not matching the treatment modalities, because we are not understanding the pathology of ARDS at the onset itself. Okay, so we need to remember, we all know the classification. Whenever someone asks us, from the time we are in MBBS or MD, we have been telling it is classified into pulmonary causes, extrapulmonary causes of ARDS. So all of this was thought about, and a lot of trials were done. Few trials showed positive outcomes for a particular treatment modality. Few trials did not show improvement. By and large, if you are talking about that, the use of steroids. Okay, earlier when a lot of steroids were used in ARDS, it did not get better outcomes. Wherein we saw the recent two trials in ARDS, that is the Dextra ARDS trial as well as the recovery trial for COVID patient, showed better outcomes with the use of steroids. So how did this come across? Probably we understood the pathology of the ARDS in these group of patients. This is one of the reasons why we need to understand what type of subphenotype of ARDS that your patient is having when they come across to the ICU. Okay, so Earlier on I spoke about ultrasound at large, especially ultrasound of the lung. Why is it more important? Because off lately chest imaging which was done, and one of the limitations when they looked at for Berlin's criteria was whenever they mentioned about bilateral chest infiltrates, out of probably 100 people, if you take, roughly 30 to 40 people did not identify it correctly. So there was an ambiguity in diagnosis of ARDS itself based on the imaging criteria. So that is one of the probable shortcomings of the Berlin's criteria, limitations of the Berlin's criteria, amongst the others which followed. Okay, so again, another shortcoming of the Berlin criteria which was seen was patients who had been categorized as early ARDS or mild ARDS with a PF ratio between 200 to 300, just with the initiation of a probable NIV with PEEP of little more than 5, they improved. Okay, and they came as came out of ARDS within a day or two. Okay, so probably at that time the only pathology that could have caused this is a cardiogenic cause or a fluid overload state. So just by correcting these issues, they were declassified from the definition of ARDS. Okay, so these were the shortcomings which were used at that time. So these things were addressed in the modifications of the Berlin's criteria, that is the Kigali's modification, as well as the newer ones which have come across, that is the new global definition. So the best thing that they looked at was the accuracy of detecting lung pathologies were more higher in a lung ultrasound as compared to an X-ray. Okay, so that is one thing. Along with this, they felt that PEEP titrations, etc., and the etiological classification of ARDS is necessary for the treatment approaches that we follow across. So all of this were addressed in the newer definitions and the precision medicine which is coming across. So this class is basically about precision medicine in ARDS. So if a question is asked about subphenotypes of ARDS or precision medicine in ARDS, you can write all of this. Okay, so please go back and read about it. Okay, so again, still a lot of questions are probable. Okay, as time is progressing, new and new questions are being asked. So please don't be reading only definitions of ARDS. Probably they can ask you to critically analyze the definition of ARDS. At that particular time, you have to write about the points which I've mentioned earlier, and please read about it. Okay, so please know what are the shortcomings of the diagnosis, and that why few trials went into negative trials, or leave few, there are multiple trials which are negative in ARDS. Okay, so to answer all of this, the focus of lately in the last 10 years or so has been on precision medicine. Okay, precision medicine usually deals with the actual etiology, the pathophysiology, and management associated with that. Okay, so usually it consists of accumulating the data, looking at multiple points at the disease process, and then tailoring the treatment towards that disease process. Okay, so that is how we come across this particular topic. Okay, so we know that there's a lot of treatment modality between mild ARDS, moderate ARDS, and severe ARDS. Okay, one thing based on the ARMA trial, we all know that low tidal volume ventilation has a better outcome. That's why we go at 6 ml per kg predicted body weight type of ventilation, along with a lot of other things which did not show much benefit. Again, Proseva came up with a better outcome. Okay, so mortality benefit was seen. So this is how we tailored across, not knowing the exact etiology. Only thing we knew is the patient has ARDS based on a certain definition at that point in time, be it ACC guidelines or Berlin's definition, or of lately new global definition. Okay, so why do we need this? So the need for a phenotypic or a subphenotypic classification of ARDS is because ARDS itself is a heterogeneous type of a disease pathology. Okay, so firstly, it is a syndrome. Okay, so we have to know that it is not a disease per se. It is a constellations of signs and symptoms which causes the syndrome. Okay, it can be because of multiple reasons. Okay, and based on that, the treatment response also will be different. Okay, so that is the reason we need to know this. Okay, so how will we go across? Usually, we need to understand the distinct clinical and biological phenotypes of ARDS when it is present, so that we can tailor make treatments based on the subphenotype which is identified in that particular patient. Okay, so this is what we call it as precision medicine. Okay, so ARDS big background, we know a lot. Okay, so based on Ashbaugh's definition, and then Berlin's criteria, then it spoke to you about the limitations. So coming to the definition of phenotype, subphenotype, and endotype, I've also provided an example so that you understand this. Okay, what do we mean by a phenotype? Phenotype is an observable trait due to a gene environment interaction. Okay, for example, in ARDS, you have a host and an environment or a pathogen interaction which is seen, and because of which there will be lung damage, which we call it as ARDS. In a subphenotype, it is a subset of ARDS. Okay, so you think about a patient who is having ARDS. It can be due to two reasons. Okay, some might have hyperinflammatory, or some might have a hypoinflammatory type of ARDS. So how do we know the subphenotype? We need to find out the endotype. Okay, so the endotype is a part of the subphenotype. How do we know that? If it is hyperinflammatory, we'll have a higher presence of interleukin 6 or a tumor necrosis factor alpha. Okay, all of this will be there. So this is how we know the biological mechanism, what is causing the subphenotype of a phenotype. Okay, so they are all interlinked. Okay, they are not separate here. Okay, so first we have the phenotype, that is the ARDS as a whole. Then we have a subphenotype, that is hyper versus hypoinflammatory. And when you're thinking about subphenotype, you need to know the endotype. Endotype will let you know what is the subphenotype, whether it is hyperinflammatory or hypoinflammatory based on a biological marker. So what is the biological marker that you use? It can be interleukin 6 or tumor necrosis factor alpha. Okay, there are a few examples. Along with this, we go to the treatment plan. So how do we treat the patient? It is based on the type of subphenotype. Okay, so if it is an inflammatory type of or a hyperinflammatory type of ARDS, probably the patient will have higher interleukin 6. At that particular time, targeted tocilizumab can have better outcomes. So that's why when we saw a lot of trials in COVID ARDS, few trials came positive with the use of tocilizumab and few came as negative. And then when we saw earlier use in hyperinflammatory patients, they showed that you have to use interleukin 6 as the cutoff value. Okay, so if the patient's interleukin 6 is not very high, then even if you give tocilizumab, it wouldn't cause any effect. So just you'll be spending some money and the cost would go up and the outcome would not be good. So understanding all of this is very much paramount to know your treatment goals, and anticipated outcomes can be improved if you go understanding the disease pathology. Okay. So based on all of these studies, okay, even ESICM has of lately, given that whenever there is a patient with ARDS, you need to find out the interaction between the host and the environment so that you can classify the clinically observable traits and then categorize them into a subphenotype. Okay. So usually you have to look at the combination or a pattern of traits which will help you to define a subphenotype. Okay. So how do we go about? We have the ARDS definition. Okay, so you can continue still using the new global or the Berlin's criteria itself for the diagnosis of a ARDS, which is your phenotype. Okay, so again you have the criteria which are already known to everyone, like your PF ratios, bilateral opacity, acuteness of onset, and ruling out the cardiogenic or the non-cardiogenic part of the pulmonary edema. Okay, which happens. So with this, you'll have a lot of people falling into the category, right? A lot of patients would fall in. Earlier, what we were dividing them into mild, moderate, and severe. That is based on your PF ratios with the PEEP set of more than 5 centimeters of water. Is that enough? Is that going to help us, tailor a treatment? Probably yes, probably no. Okay, so by and large, we know if, thanks to the pandemic, that even though we followed protocol based on the approaches mentioned earlier, we did not have successful outcomes. So why did we not have it? Probably it is because we didn't treat them properly. Okay, so firstly, in the subphenotype, get the timing right. Okay, whether it is an early type of an ARDS or late type of ARDS. Why does it matter? Early, there are few treatment modalities which has to be initiated at that particular time. If you choose a patient, especially when we know about initiation of ECMO, etc. So what they say, one of the contraindications itself for the initiation of a VV ECMO is if the patient is having a PF ratio of less than 80 or 50 for more than 5 to 7 days, the probability of outcome of this patient would be very poor, correct? So something like that. Okay. So if you're tailoring a particular patient's treatment protocol, you need to know that as well. So timing is one thing. So in timing, you categorize them as early versus late. Next will be the etiology. Majorly, you can categorize them as to pulmonary or extrapulmonary. Okay, or else you can also do it like inflammatory, non-inflammatory, infective, non-infective, etc. Okay, so based on that, we can categorize them again into a lot of other subsets. Okay, after the etiology, we have physiology. Okay, wherein you have already identified the etiology, identified the time of onset, and the patient has been initiated on a particular ventilatory strategy. At that particular time, you need to look at what subphenotype the patient is, whether the patient's driving pressures are going up, the PEEP requirement is higher, if the plateau pressures are high. Okay, all of this. If you feel that the driving pressure is going up, the power is increasing, probably the patient is not going to respond to your ventilatory strategies. At that particular time, if you have an idea whether this patient is hyperinflammatory or hypoinflammatory, then you can take a decision as to what to do next. Okay, whether the patient, if the patient is not improving because of an hyperinflammatory pathology, probably using immunomodulatory therapies like tocilizumab might be a better outcome. Similarly, organ failure, protein biomarkers, imaging, especially imaging will help you a lot. Imaging will help you in categorizing the patient into a focal type of a pathology or a non-focal type of a pathology. Okay, so to summarize the whole slide, firstly, you have diagnosed an ARDS. After the ARDS diagnosis, you need to categorize them into a subset of population based on a few characteristics. What are those characteristics? They are nothing but your subphenotypes. So they can be categorized based on timing, etiology, physiology, organ failures, biomarkers, or imaging. So if you label them here, they can fall under one or two categories or more than one, two categories as well, depending on what is happening with their disease process and treatment protocol. Okay, so if you identify that particular subset properly, then you can make a tailor-made adjustments for treatment. Okay. So, what is the purpose for phenotyping? There are two treatment strategies or enrichment strategies. One, you can prognosticate the patient. Okay, you can identify which patient is likely to, improve, or who is likely to have a better outcome. And based on that, you can also, make trials. Okay, so the power which you usually have to choose for a clinical trial, you can usually know based on the subset population if you're doing. Okay, otherwise, if you take ARDS as a whole, probably the accuracy level would drop. Okay, so here by using subphenotype, the accuracy levels will go up. Okay, so that causes prognostic enrichment, and the diagnostic power would increase. Okay, so that is one purpose of phenotyping. And when you come to the treatment aspect, it helps you to narrow down a particular strategy for that particular clinical syndrome. Okay, so that these are the two major purposes for phenotyping. Coming to subphenotypes based on cause, I've already told you, but I'll be going in small details. These can be added in your exam paper. Okay. So, firstly, direct causes or indirect causes, as I've already mentioned, pulmonary or extrapulmonary causes for ARDS. Okay, direct is your community-acquired pneumonia, aspiration, drowning, etc. Indirect can be your systemic causes like sepsis, pancreatitis, burns, etc. So implication is direct ARDS may benefit less from recruitment methods, whereas indirect ARDS can show better response. So this is what we need to understand, correct? So this is what we usually understand by the pathology itself. So we have been doing this, but we have not categorized this. It's not like we didn't know about it, but we just ignored this part of the disease process of ARDS. Coming to this biological subphenotypes, we have mentioned earlier hypo and hyperinflammatory subphenotype. So hypo, as the name goes itself, it has lower interleukin 6, 8, tumor necrosis factor, etc. But else can have some anti-inflammatory properties like higher protein C, bicarb, etc. So here, what they have noticed is they have a better outcomes and lesser chances of organ failures as compared to the hyperinflammatory subphenotype, which usually has multi-organ failure, and higher mortality. Okay. Coming to the clinical relevance, we know hyperinflammatory, usually there will be involvement of both the alveoli and the vasculature. So usually they require higher PEEP. Lot of trials have undergone in ARDS, especially when they saw this hyperinflammatory picture. They even tried the role of simvastatin, etc., but they did not give any better outcomes. Okay, so probably here the ambiguity was in including both hypo and hyperinflammatory, and that's the reason probably simvastatin did not work. Had it been that they had categorized the patients as hyperinflammatory and only based on that if they had done it, the subgroup analysis would have helped us understand. Okay, so this is one thing, as that is a takeaway point from this particular slide. Okay. Coming to the next thing, again, this is a continuation of hypo and hyperinflammatory states. I mentioned earlier about inflammation and multi-organ failure, correct? In hyperinflammatory pathology, what we look at is both the alveolar involvement as well as the vascular involvement might be present. It cannot be generalized. Say sometimes if it is in the early stages, it might be depending on the type of ARDS. If it is an extrapulmonary type of ARDS, the pathology might be in the vasculature only, and the lung alveoli would be all right. But if it is a direct, type of an ARDS or a pulmonary type of ARDS, the pathology would be in the lung. So alveolar hyperinflammation would be higher as compared to vascular hyperinflammation. So we cannot, generalize it on the whole. So if we understand these pathologies, then we can understand and titrate or tailor make our approaches. Like I've told you earlier, PEEP strategies will work better for extrapulmonary ARDS, correct? Wherein your problem with the lung is only with the vasculature. So the alveolar recruitment and all will have a better outcome because the alveolar is yet safe here. Okay, whatever is happening is only because of the vascular hyperinflammatory state. So this is how we need to understand about the hypo and hyperinflammatory direct versus indirect type of subphenotypes of ARDS. So coming to the next part of the subphenotype, that is your radiological subphenotype. Usually, I told you earlier, it is focal or non-focal. So why do we need to know? We will be discussing about proning in my upcoming classes, where I'll be explaining about the recruitability and the response and why Proseva gave a very good result. Okay, so we know very well that in non-focal ARDS, the diffuse loss of variation will not be that great. Okay, but so I'm sorry, in non-focal ARDS, there will be diffuse loss of aeration, and the response to PEEP recruitment will be better. Like you will have a higher PEEP if you insert, because it's a diffuse loss of aeration, the recruitability will be better. But what happens in focal ARDS, only part of the lung is involved, right? Because a part of the lung is involved, you will be increasing the PEEP, but PEEP is generalized here. So because you generalize the PEEP, the normal lung which is there also gets inflated, and that will not be good, and your ventilation perfusion mismatch would increase. So this can be offset. Instead of increasing the PEEP, if you prone these patients, they have a better response. So this is how you can choose your treating modality. Okay, so in non-focal ARDS, because it's a diffuse loss of aeration, the response of PEEP titration would be better. Because in focal ARDS, there will be something called as a pendulum phenomenon which happens. So these patients would be a better responders to prone position. Okay, so here again, to diagnose itself, it will become a big problem. Focal ARDS and non-focal, the best modality is CT. X-ray, ultrasound would not be up to the mark. Sometimes ultrasound can give a better imaging as compared to chest X-ray, definitely. Okay, so this is one of the limitations for categorizing based on radiological subphenotype. Coming to physiological, one thing is latent class and revealed. What do I mean by latent class and revealed is latent class is something that happens over time. Okay, earlier I mentioned about timing, right? So initially we'll not be able to diagnose shunt. Okay, initially we'll not be able to give an accurate definition of the lung compliance or the value of the lung compliance. Okay, all of this would take time for us to get, especially the CT imaging, etc. Definitely no one here would be practicing to get a CT on day one when we diagnose ARDS, right? Unless we see something very grossly abnormal on the X-ray. Okay, so physiological subphenotypes usually are based on these parameters. Okay, dead space fraction, shunt, compliance, and CT imaging. Okay, what do we mean by revealed is usually whenever we have a patient with ARDS who has been diagnosed and we have them under a certain lung protective ventilation, if they are improving with the ventilatory strategy, then it is better. That is a recruitable lung or a non-recruitable lung. Okay. So despite this, along with that, if they have a poor PEEP response, then the mortality rate would be higher for such patients. Okay. So we usually have to be categorizing them between recruitable ARDS and non-recruitable ARDS. Okay. So whenever you have a non-recruitable ARDS, however, you try to improve the VQ mismatch, be it with proning, etc., or even if you think that the patient can go on an ECMO and they can become better, that might not be the cause. Okay, so if we understand these particular subphenotypes, especially the physiological subphenotype, especially recruitability, when we are talking about, we not only talk about this in physiology, we should also talk about the VO2 and the DO2 when it comes to ECMO as well. Okay, so if you see the patient's requirement and supply mismatch is very higher, okay, the ratios are going higher up, so probably the ECMO would fail in these patients as well. Okay, so that is about physiological subphenotypes. Remember, it is about your supply demand mismatch, appearance of shunt, okay, and increased dead space ventilation and poor lung compliance. Okay. Temporal phenotypes. Temporal, as the name suggests, it's about the timeline of occurrence. Okay, so most of the data which usually comes across would be static data. Usually, first 24 to 48 hours would be different, and if you're taking patients who have been prolongedly ventilated, that outcomes and the data would be different. So whenever we are talking about temporal subphenotypes, remember it is more or less data driven. It is more or less research driven. Okay, so here what they will usually look at is whether this particular patient who has been diagnosed with ARDS is in the early part of ARDS or the late part of the ARDS, whether this particular strategy will help them or not. Okay. So I was telling you earlier about mechanical power, dead space ventilation, etc. So whenever we are seeing this, the earlier we diagnose this patient to have worsening of ARDS and ventilatory strategies by the tune of increasing driving pressures, increasing plateau pressures, and increasing mechanical power, then probably we need to think about the initiation of ECMO in such patients if proning has also failed. Okay, so this is temporal subphenotyping and titration and tailoring the approach for management of such group of patients. Okay, so that is about timeline oriented subphenotyping. So these are the various subphenotypes. To conclude, ARDS phenotyping, subphenotyping is usually the precision medicine in ARDS. The key barriers is previous data are all mixed data. So there is no real bedtime tools still available for us to categorize them at the time of admission. It takes time for it. So temporal driven phenotypes may still be a little difficult. Okay, so only thing is whenever we have a diagnosis and we have a certain strategy of management for these patients as per guidelines, it will be better if we can categorize them based on etiology, phenotype based on hyperinflammatory or hypoinflammatory, and then treat them based on these two things. The outcomes can be better. Okay, so if we identify them earlier and then initiate the treatment better, then probability of them developing a multi-organ failure and in turn increasing the mortality would come down. Okay? So this is by and large about subphenotypes of ARDS. If there is any question, I'll be taking. Thank you. I've not given the this uh, reference article for this. I'll be sharing the reference article in the group today. Okay. Any questions? Okay, Bhagesh, I think so. This end.